So first of all, I want to thank uh, Patty and Donna and the council for this opportunity. It's really a privilege to talk with you all. I want to talk with you about the idea of precision psychiatry and how that may improve the outlook for mood disorders, which are very common. And actually, because they're so common, the chances are 1 in 4 of us in this room has had or will have a mood disorder at some point in our lives. So that means depression or bipolar disorder. What do I mean by the challenge of mood disorders? Well, I think I have the wrong clicker here. Let me give you some facts that sort of tell that story. Depression is the #1 cause of disability worldwide. Bipolar disorder, on average, it takes about 6 to 10 years from the time somebody starts having symptoms to when they get the correct diagnosis. Most people with mood disorders don't get treatment, and when treatment is given, it is often a sort of trial and error process that can take months. One of the, of course, terrible complications of these disorders is the problem of suicide, which is actually the second leading cause of death among young people. And we've actually seen nearly a 60% increase in youth suicide in the last 15 years. So, as a clinician, every week I confront the challenges or limitations of what we face with these conditions. And let me give you an example that's not atypical. This is a patient, Megan B., who was a school teacher in her early 20s who began having depression about a year ago. And she started this process of trial and error with her prior clinician, trying to find the right medications, went through a series of medication options with limited benefit. And after about 6 months, she ended up making a suicide attempt, ended up in the hospital for a couple of weeks, and after discharge, couldn't really return to work and ultimately had to take a leave from her job and go on disability. And this is unfortunately not a very uncommon story. And I've highlighted a couple of aspects of her history that sort of highlight places where maybe we could do better. So first of all, what if we could choose the best treatment from the start and not have to go through this trial and error process? Could we predict and prevent suicidal behavior? Could we even predict and prevent mood disorders from beginning in the first place? So about 2 years ago, we established the Center for Precision Psychiatry to try to find new ways to address these and other urgent challenges. And our motto is, or our mission is, to drive innovation to implementation. That means to bridge this gap between research discoveries and clinical practice by using big data and 21st century tools to help us better diagnose and treat and prevent illness. And it's actually part of a paradigm shift in medicine more generally called precision medicine. And the idea, and this has actually already had transformative successes in areas like cancer and heart disease. So the idea is to move beyond this one-size-fits-all trial and error approach by targeting individual differences in our biology and lifestyle and environments to do better with how we treat or prevent or diagnose disease. And the fact is that most of the treatments that we have are still based on what works for the average person. But of course, none of us is the average. We are all unique. So one of the tools that we now have at our disposal is artificial intelligence. And you've probably heard some about artificial intelligence recently in the news. Actually, we mainly encounter it with companies that are trying to predict what it is that we're going to like or want to buy. So social media companies like Twitter or Facebook use it to predict what do we want to see in our feed. Netflix or Spotify use it to sort of predict what videos or music we would like. And the way they do this is by analyzing vast amounts of data about people's behavior and then building algorithms or models that can predict future behavior. But the good news is that those same tools are now available in healthcare settings to help us predict more, to predict important outcomes or to support clinicians and patients in making better decisions about what to do. And one of those decisions is what to do when you're trying to pick a medicine, for example, for a patient like Megan. So let's imagine two patients, Megan and another patient, Tom. And when we are selecting an antidepressant, let's say they are coming to us with depression, we typically have four different kinds of medicines that we think of first line. An SSRI, like Prozac or Lexapro, an SNRI, which would be something like Effexor, bupropion, which is also known as Wellbutrin, and Remeron or mirtazapine. So those are usually our first four main choices. Now, interestingly, the best studies show that the probability on average that somebody's going to respond to one of those medicines is actually the same across all those medicines. So that's what we have to go on. And typically what we do is we start with one, we start this trial and error process and hope that it works. But if it doesn't, after a couple months, we move on to another strategy. So to try help change that, we recently used electronic health records and artificial intelligence to develop an artificial intelligence model with data from 17,500 patients to predict which medicine or what's the likelihood that somebody's going to respond in the 4 to 12 weeks after they begin treatment. And this is results that you're seeing on the bottom there for the SSRI. And the model actually correctly predicts what the treatment outcome is likely to be about 75% of the time, which is better than what we're doing now. And what you see here, interestingly, is for Tom, the model predicts that he has a 94% chance of responding to an SSRI, which is great. But for Megan, it's only 28%. So if we started with an SSRI, that might be pretty good for Tom. The beauty of this model or this approach is that we can ask, well, what should we do? If an SSRI doesn't work for Megan, what should we try? And the model's key sort of advance is being able to predict response to different antidepressants. So I don't know how clearly you could see this, but for Tom, most of them are going to work pretty well. And the SSRI is actually the best choice. But for Megan, it turns out we would have been better off starting with the Remeron. So you can see that if you had this kind of information up front, you might spare people potentially months of trial and error treatment. Another area that we've really focused on and applied these kinds of tools to is the problem of suicide, which, as I've mentioned, is a leading cause of death. And amazingly, rates of suicide have not dropped in a century and sometimes have really increased a lot. We actually do have methods for preventing self-harm, but we're not very good at knowing who's really at risk. And it turns out that studies have shown that we clinicians do no better than chance at identifying who's really at high risk. So a few years ago, we began using the vast resource of electronic health record data along with artificial intelligence, again, to build powerful new risk prediction models that can identify people who are at the highest risk. And with support from the Tommy Fuss Fund, we developed a model that could predict suicide attempts using data for about 2 million patients. And the model was able to detect 45% of all attempts on average 2 to 3 years in advance. We then showed that this approach worked just as well in 5 other healthcare systems around the country. And we went on to do an extensive economic analysis to ask how good would a model like this have to be for it to be cost effective to use in primary care. And in fact, the results showed it would be cost effective to do if you pair it with proven methods of suicide prevention. And then more recently, we conducted a very large study in our emergency department, almost 2,000 patients, who had come in, and they were seen by clinicians. We asked the clinicians, what do you think is the chance that this patient is going to make a suicide attempt in the next month? And then we compared that to what the algorithm predicted. And once again, the results were sort of sobering. Clinicians performed no better than chance, but the algorithm clearly outperformed. And that's not surprising because this kind of big data artificial intelligence approach is using so much data to kind of come to a conclusion, much more than we as an individual clinician could ever kind of entertain in our minds. And one thing that was really sort of striking is for the people who were classified as high risk, a staggering 40% went on in the next month to make a suicide attempt. So we have now gone ahead and built an app that can be integrated into the electronic health record at the point of care and can alert clinicians to a patient's individual level of risk and then guide them through the development of a personalized treatment plan. And, you know, we've come a long way in just a few years from having this technology to actually being able to be in a position to implement it. Along with colleagues at 3 other healthcare systems, we've also used these methods using data from more than 3 million patients to develop algorithms that can predict the onset of bipolar disorder, which, as I mentioned, is important because most people go long time before they get the correct diagnosis, and the longer that goes, the worse the outcome. So the individuals who are identified as very high risk in this model went on to have a 19-fold increased risk of bipolar disorder. What about preventing mood disorders in the first place? What can we tell people about how to, say, prevent the onset of depression based on what we know about risk factors? Well, try not to have affected relatives. If possible, avoid trauma in your childhood and just say no to drugs. So these are not super actionable things that we can easily control. But with support from the Demarest Lloyd Foundation, we have now conducted a series of large studies using big data, including hundreds of thousands of individuals and even genetic data, and have found 2 actionable factors that are causal and modifiable for the prevention of depression. And what's even amazing is that regardless of your genetic risk for depression, which we can assess, or your history of trauma, these things are essentially equally protective. Do you want to guess what they are? Anybody? Exercise. Those are all good guesses. So here's what they are: physical activity or exercise and social connection. And it turns out that each of these has very powerful effects. And you may be hearing more about this in a moment. For example, if you just replaced an hour of sedentary activity with an hour of moderate physical activity like fast walking, these analyses show you would lower the risk of developing depression by more than 25%. So this is just some of the areas that we're trying to bring precision to in mood disorders to try to do better in what we can offer patients for treatment and prevention and diagnosis. I'm personally thrilled to be part of a department that you've already seen is just extraordinary and is driving the field forward in these ways. And I think there's a lot of reason to be hopeful. And I'm just super grateful to all of you and to my colleagues to be part of a place which I think is going to usher in this new era of precision psychiatry and hopefully improve a lot of lives. So thank you very much.